Early. Good morning, everyone. My name is Chris Nelson. I'm a psychologist. I'm at Sloan Kettering Cancer Center and want to talk today about recent innovations in sexual psychology. In terms of disclosures, some grant disclosures, some NIH grants that have impacted some of the work that I'll talk about, none in terms of speaker bureau. I do have some consultant work with Movember. In terms of ownership, none, other, none, and then no off-label products. And so getting ready for this talk, preparing for this talk, I surveyed a number of my colleagues who are sexual medicine and also mental health professionals and asked them what they thought were the most recent innovations in sexual psychology. And by far, the response was mindfulness and Laurie Brado's work in Canada. And so when we think about mindfulness interventions, the concept of mindfulness, it's also grouped together with a type of therapy called acceptance and commitment therapy as well. But ultimately, mindfulness is defined as practicing non-judgment, present moment awareness, things like body scan and focusing on breath. Mindfulness-based cognitive therapy is generally how this is implemented in interventions and spearheaded by Laurie Brado's group. And then use basically appreciation for body sensations, move away from negative distracting thoughts so you can focus more on the pleasure and the intimacy in the sexual situation. Act-based approaches tend to reduce the influence of anxiety, kind of assume that patients are people, if they're having difficulties with sexual problems, will be anxious, but how do we reduce the influence of that anxiety? Accept stress as a natural aspect of the process, commitment to goals, and a willingness to act in accordance with one's goals and beliefs. And so here's a good example of some mindfulness research. This is published by Laurie Brado, and this is delivered in a group therapy format. And so mindfulness-based cognitive therapy with supportive education versus supportive sexual education alone. You can see here there were 148 women, so a nice large sample. And 8-session treatment delivered weekly. Participants completed measures at baseline, and then immediately post-intervention at 6 and 12 months. Outcome assessments included things like sexual desire and arousal, sexual distress, relationship satisfaction, rumination, and then global impressions of change. And you can see the results were actually fairly positive, right? Demonstrated that mindfulness-based cognitive therapy to be efficacious in increasing relationship satisfaction while decreasing sexual distress, sexual problems, and numerous, and ruminations about sex. And so what are the concepts and exactly what is mindfulness-based cognitive therapy when it's applied to sexual situations? And so again, it's non-judgment, present moments of awareness, used again to appreciate bodily sensations. And techniques used are things like body scans and meditation. Body scans to hopefully relieve things like pain, tension, and any other things that out of the ordinary that help you again focus instead of on distracting aspects of anxiety or pain, focusing on the pleasure and the enjoyment of the situation. Mindful breathing, movement and listening, self-exploration of touch, sexual specific sexual awareness, addressing and working with difficulties, and then acceptive thoughts, and then challenging maladaptive thoughts. And if you look at the literature in mindfulness-based cognitive therapy, stress reduction, cognitive therapy, so we see it in men with situational erectile dysfunction. So mindfulness help patients normalize their experience with ED, lower their anxiety, increase their self-awareness of their anxiety, enhance present moment awareness. Sexual dysfunction in women. Pilot studies indicate feasibility, reduction in sex-related distress, and improvements in sexual satisfaction, desire, arousal, and satisfaction. In couples. In prostate cancer, acceptance and education surrounding potential permanent sexual changes, improvement in sexual satisfaction. Couples showed reduction in sexual distress and improvement in sexual satisfaction. And so you can see the outcomes in terms of mindfulness-based, in terms of these innovations, as really kind of the highlight. in terms of what my colleagues assessed as basically kind of the most innovative in sexual psychology. In this, I just want to talk about some of my work as well, because in this also includes approaches in acceptance and commitment therapy. And I've worked on aspects of men avoiding sexual situations when they have difficulty with erections because they become nervous and anxious about the sexual situations. And when you do that, there's disappointment and shame related to a man who has erectile dysfunction, this concept that I'm not a man anymore, distress related to depressive symptoms. And then there's fear and anxiety entering the sexual situation, right? Fear that their erection won't be firm enough, right? Sometimes the notion of injections or any use to help with erections is a turnoff, and the whole process is humiliating. Avoidance of sexual situations, loss of valued life experience, and then increased frustration, distress, and depression all leads to a sense of avoidance. And so in acceptance and commitment therapy techniques, what we do is we try to shift the focus and give men a different mindset. So instead of focusing on the problem when they think about sexual situations, we first focus on the value and why it's important for them to think about getting their erections back. Why is it important for them to be sexual again? And we start with the values and the importance to them, because the motivation is going to come from those values and their goals. Then the notion of acceptance, accept that they're going to be nervous and anxious. That's now part of the process if they've had difficulty with erections. Then the concept of willingness. The concept of willingness is the idea of being nervous and anxious about something, but doing it anyway. And why would you do that? It goes back to your values and goals. And so hopefully what that leads to is action, and then hopefully growth, some psychological growth, some increase in intimacy using the erectile dysfunction treatments, which just adds to commitment. And kind of in our data and our analysis, this is in 200 men. We've shown essentially that men in terms of median weekly injections between, this is an enhanced monitoring education group against our ACT group, we can see that the median level of injections per week has increased and is larger in the ACT group. And in terms of rehabilitation, almost double in the ACT group. And so in terms of some mindfulness and this concept of acceptance and commitment as something that's relatively new in the field, but also I wanted to comment on a little bit bigger concept, is that how can sexual psychology impact clinical care? And that is, do we, not only me as a psychologist, as a mental health professional, but we, all of us, need to think differently in how we treat and how we care for our patients. And hopefully what we've done in terms of mental health professionals is that we've been able to push and advocate for a biopsychosocial perspective, where sexuality, both in thinking about sexual problems and diagnosis as well as treatment, right, is compounded and kind of needs kind of a multidisciplinary approach: the biological, the psychological, the kind of performance anxiety, impaired self-esteem, depression, trauma, the psychosocial, right? Their upbringing, their cultural values, and then the interpersonal, quality of past relationships, quality of current relationships. And how do all of those go to impact sexual functioning when a patient comes to your office and is complaining about a sexual problem? And so what we've seen, I think, in the past 5 to 10 years is an integration of this notion of the biopsychosocial approach in our research, and hopefully all of us working together more productively to help treat patients. And here are some examples. So Ishwish process of care for the management of hypoactive sexual desire disorder in women. This is Anita Clayton's work. At least she was the first author, but led this group. And I'm looking at Sue, who I'm sure was a part of this as well. And so ultimately, in terms of this process of care model for HSDD in females, it was developed to provide evidence-based guidelines for things like identification, diagnosis, and the target and the treatment of female HSDD. Algorithm was developed using a modified Delphi approach, 17 multidisciplinary international panelists. And you can see here we're starting at the biopsychosocial approach integrated with multidisciplinary approach. And iterative process, including review and summary of current literature, debate and discussion of divergent views concerning the assessment and management of HSDZ and the consensus development of these guidelines. And so ultimately, the guidelines start with diagnosis, use the decreased sexual desire screener. It says on the previous slide, actually it didn't make this slide deck, but there is this screener that is effective. And then assess for other sexual problems related to arousal, orgasm, and pain. Determine if things like it is lifelong or are acquired, generalized, or situational. Physical exam, and then identify potentially modifiable factors. And these modifiable factors are, again, a good example of the biopsychosocial approach. Ultimately, which led to kind of this algorithm in terms of treating HSDD in women. And so start with asking permission, and then if they report low sexual desire, move here to an assessment. Is it generalized or acquired? And then we move on to kind of where they go in these process. And so are there modifiable factors or no? And then if there are, it kind of goes on different algorithms, but ultimately education, explain in terms of modifiable factors. And then if those modifiable factors are addressed and there still continues to be a difficulty, move to here kind of treatment, which includes things like medical treatment and also sex therapy, demonstrating the importance of this biopsychosocial approach. Another example of the biopsychosocial approach was actually talked about a lot this morning in terms of these guidelines for sexual health care following prostate cancer treatment for prostate cancer patients. I won't go into this in detail because it was talked about by Dr. Whitman in the panel this morning, but these guidelines were developed and ultimately supported by Movember, but ultimately used a biopsychosocial approach to develop these guidelines basically for the best care and the best treatment for prostate cancer patients after their treatment. So 47 statements generally focus on education, both of the patients and the partners, and then openness and inclusivity. So they talked about this primary statement, this first statement this morning, asking the question, a clinician-initiated question of patients, asking the questions in terms of have these treatments impacted your sexual functioning? And so this algorithm was also shown as well. If you're interested in these guidelines, here's the code right here, the QR code. Scan that, those guidelines will come up. I see a few people starting to take some pictures. I'll give you a second to take a few pictures of those for those guidelines. But again, another example of the biopsychosocial approach. Okay, another example is sexual recovery and rehabilitation in ovarian cancer survivors. And so we know that ovarian cancer treatment can have significant impacts on sexual functioning. And ultimately, kind of few interventions have addressed this. And this is work by Dr. Bober. So ultimately developed and tested a brief targeted psychoeducational intervention. Intervention components included things like sexual health education, CBT, that's cognitive behavioral treatments-based strategies, relaxation training, follow-up booster phone calls. Results showed improvement in sexual functioning and distress. Improvements were maintained through a 6-month follow-up period, which actually shows good sustainability. Participants reported high acceptability. Study supports feasibility of low-intensity sexual rehabilitation, combined then with the biological treatments, hopefully to help kind of, again, our best treatments for sexual health for these women. More research is needed to test this in a broader context. My last example is how you integrate the biopsychosexual approach within clinics. And here is an example by Dr. Matthew in terms of his prostate cancer clinic, where he integrated these perspectives. And so sexual dysfunction is common, we know, after radical prostatectomy. Biomedical aids alone often fail due to poor adherence. Prostate cancer rehabilitation uses a biopsychosocial model. Clinic features things like interdisciplinary team, urologists, counselors, and psychologists. Partner involvement in treatment in pre- and post-operative education and continuing of care. So in terms of this as a 2-part model, look at erectile rehabilitation and intimacy maintenance for those who are using these treatments. Erectile rehab includes regular sexual activity, pro-erectile therapies, and psychosocial support. So support includes intimacy counseling, communication support, adaptation of sexual changes. So initial data shows high uptake and satisfaction. So in terms of summary, sexual psychology innovations. Clearly, in terms of innovations, what we hear the most is Lori Brado's work in terms of mindfulness has been one of the most innovative aspects to the field. But also in terms of mental health professionals, hopefully what we're helping doing is pushing the biopsychosocial model, and not only pushing it, providing data for its effectiveness. So hopefully it becomes the gold standard way that we all work together to provide the best care for our patients. Thank you.